almost we have a largest number of diabetic population. We have 52 fixed drug combinations approved by DCGI. Almost more than 500 brands of fixed drug combinations are marketed. You might be aware recently some FDC combinations have been banned by the Indian regulator, probably because of the lack of the rationality of the fixed dose combination regarding the interactions as well as the mechanism of action. And the 27 FDCs were in combination with metformin out of that. And so you're all aware that Indian trends, there's a rising prevalence of type 2 diabetes as well as Indian patients with type 2 diabetes, they do not achieve the therapeutic goal, okay? According to the ICMR INDIAB study, which is already done with the previous speakers also, almost more than 69% of the patients are above 7%, and if it can take around more than 10%, 5.3, which is far above the recommended targets. And as you know that the poor glycemic control, there is a risk of complication increases, and the good glycemic control offers some multiple advantages which have been proved by the UKPD's follow-up study. It's called glycemic memory or legacy effect. And in spite of that, there is a residual cardiovascular risk prevailing after the standard of care. The targeting it with an anti-diabetic agent with proven risk reduction. I think Dr. Mahadevan was telling you about the off-target uses of the anti-diabetic drugs, in which majority of them were focused to cardiovascular thing. When a drug is used for a diabetes control alone, but the recent the cardiovascular data, and when you conduct the clinical trials, you come out with a lot of newer findings. And certain things we are not able to explain, certain things have got a benefit, some basis, but in the thing, some drugs, the coronary artery disease almost 11.4 to 28% affects the Indians at least 10 years earlier to Caucasians. The stroke is 0.5 to 6.9%, okay, that's 42 times more prone in diabetics, and the PAD prevalence is lower in the Caucasians. Just to know that there is increased risk of the coronary artery disease and cerebrovascular disease. And of course, whenever you do not treat the diabetes properly, the uncontrolled diabetes, sometimes when the patient comes to you, tells her, the medicine costly, you prescribe some cheaper medication, and sometimes even if you prescribe a cheaper medication, he may not take it. The complaints may be a problem. But when you think about the complications of diabetic, for example, a person develops a diabetic kidney disease, a coronary artery disease, or a diabetic foot, needs a hospital admission. The patient needs to spend more than 5 lakhs rupees if it's a major amputation. In addition, the coronary artery disease, CKD, the risk of death is increasing. So these risks are very huge when compared to the treatment costs. So cost of not treating diabetes properly is much higher than the incremental cost of intensive treatment. There's an Indian perspective, and the poorly managed glycemia and tried to compare the incremental cost. The incremental cost wasn't much, but when the patient develops a complication, the cost of complications are heavy. So when you want to know about a drug causing a risk and benefit ratio, so the benefit you get out of a molecule or a pharmacological agent, if you think any medical treatment, if you think the benefit is more than the risk, we need to do that. So the risk benefit ratio is high, and the multiple defects and approaching the diabetes in pathophysiological terms, already detailed done by the morning speakers, which was given by Ralph DiFranco. And so by addressing the pathophysiology, effective treatment of type 2 diabetes requires multiple drugs used in combination to correct multiple pathophysiological defects. The treatment should be based on known pathogenic abnormalities and not simply a reduction in HbA1c. Therapy must be started as early in the natural history of type 2 diabetes to prevent progressive beta cell failure, about which we had a discussion, whether the progression can be modified. In fact, I was telling in the morning that the newer drugs have definitely tried to help the modification of the natural history of diabetes, and some drugs which are on the insulin independent mechanisms and drugs which are based on the GLP-1 based therapies are definitely helpful. So when you look at the 360 degrees approach, so trying to attack from the multi-pronged, so multiple pathophysiological attacks. So when you attack the disease, now we understand the ominous octet, 8 things are there, okay? So all the pathological defects you are trying to address, the glucose uptake in the muscle, the glucose reabsorption in the kidneys, and insulin secretion, and you are again looking at the alpha cells and glucagon secretion, looking at adipose tissue lipolysis, as well as hepatic glucose production, as well as neurotransmitter dysfunction. So when are we able to do this? And so what are the unmet needs in the type 2 diabetes management? Need for a glucose lowering agent with good glycemic control. Second, it needs to be oral drugs because it improves compliance, and the low risk of hypoglycemia and weight gain, and combination therapy which can address multiple pathophysiological benefits in addition to cardiovascular benefits. The CV benefits of SGLT2 inhibitors and CV safety of DPP4 inhibitors are there, and so we need to target multiple pathophysiological mechanisms. And so when you're combining two drugs, it's very important to know that these drugs should not interact with each other, and one drug should not offset the benefit of the previous drug which is already used. So when you look at the SGLT2 and DPP4, the SGLT2 mainly acts in the kidneys and causing glucosuria and weight loss. But whenever you reduce the glucose load, already the glucotoxicity is reduced. But on the other hand, you look at the DPP4 inhibitors, acts on the gut, an incretin effect, which again GLP-1 increase and GAP-1 increase, and there's an action on the dual pancreatic effects. One on the beta cell sensitivity, on the other hand, there's an increased insulin secretion as well as suppression of glucagon. So insulin sensitivity is increased, insulin secretion is increased, and on the other hand, suppression of the glucagon. Thereby overall, they are complementary to each other. And what do the guidelines say? The guidelines already are doing, everybody, I think many of you would have been aware of these slides. Whenever there is an ASCVD as well as the patient with the CKD as well as heart failure, these SGLT2 inhibitors are the preferred agents, and whenever these comorbidities are there, you need to combine. So when you combine these drugs, the HbA1c reduction is almost 1.5%. Whenever it's 1.5% higher than the individualist target, these drugs can be combined with or without. So when you have the problem with a CKD or a cardiovascular disease or a patient without ASCVD also, these combination, when you think that the patient, so you fix up, morning there was a discussion, you have to fix a target for the patient. When a patient comes with the HbA1c of 11, you should tell the patient what should be your blood sugar in the next visit and what is the target HbA1c we are trying to address. So probably when you think that target HbA1c is around 1.5% higher than the existing HbA1c, these drugs have definitely proved to reduce that. And see, these combination has been approved by DCGI. US FDA has also approved. There are 3 combinations available, and I think Emfa-Lina combination is approved by US FDA as well as DCGI and commercially available since 2018. And they're given orally in addition to diet and exercise to improve glycemic control. And so there has been studies, when you combine 2 drugs, you are worried about the bioavailability and bioequivalence, and the PK/PD of linagliptin and Emfa were not affected by the co-administration. It's very clear from the couple of graphs here. You can definitely see that the mean plasma concentration were not affected. So combining these things did not have much issue with the bioavailability and bioequivalent of the drugs as well as the PK/PD studies. And overall, the Emfa-Lina, also the fixed drug combination, has got a phase 3 studies. The fewer studies are available, and there's a drug which had initial studies to support the US submission. There was the initial combination in the metformin background, and there was a group of patients in drug-naive. One is the patient on a metformin, other one drug-naive patients. In that one group, there was an Emfa add-on to Lina in metformin background. Other one, the Lina add-on to Emfa in the metformin background. Then after some time, there's a crossover, an Emfa add-on to Lina, and here an Lina add-on to. So till that the results were since the results were satisfactory, the DCGI has given approval for this combination of Emfa with linagliptin in the Q4 of 2017, and definitely this combination has got a significantly higher efficacy in the compared to monotherapies. Okay, so when you combine the Emfa and Lina, so they did better when they combined. So in drug-naive patients as well as in a patient with the background of metformin, almost 1.8 to 1.9% HbA1c reduction when the baseline HbA1c is 8.5, as well as the early achievement of goal HbA1c in FDC, as well as durability of action. The data is available till 54 weeks, okay? These drugs seems to be working. We had a discussion regarding the durability also in the morning. So 3 to 5 times probability of reaching the goal HbA1c with the fixed drugs combination compared to monotherapies. And this data paper published, the combination of EMPHA and linagliptin results suggest that immediate use of triple therapy in patients who have failed on metformin may provide advantages over the traditional staggered treatment approach. And significant changes in the body weight as well as the systolic and diastolic blood pressure reduction, approximately I think around 2.5 to 3 kgs blood weight reduction, as well as the around 3 to 3.5 millimeters in the systolic, as well as around 2 millimeters of diastolic blood pressure reduction. So when you look into hypoglycemia, when you add two drugs, you might think that hypoglycemic rates might be increasing. But on the other hand, you will all be aware that the DPP-4 inhibitors do not cause excess hypoglycemia. So when you combine this EMPHA and LINA also, they are not going to have a confirmed hypoglycemia. Is also very comparable when used in a combination, and numerically lower incident of genital infection. So how is it happening? When you give a SGLT2, how come the genital myocardic infection has come down? It means, there's data suggests that there is an DPP-4 enzyme which is present in some bacteria and fungi may lead to less infection. So when you combine a SGLT2 with DPP-4, that's LINA with empagliflozin, the genital myocardic infection, data have come down, and the cardiovascular comparative outcomes with the combination, definitely in this thing, there is an improvement in the patients with the MACE as well as the cardiac failure population. And the CV safety has been proved with linagliptin, sitagliptin, and Saxa. All the cardiovascular outcome trials with the DPP-4 inhibitors have proved that they are CV neutral. On the other hand, when you look at the SGLT2, most of them have given a favorable effect on the cardiovascular outcome, especially in terms of a patient with a heart failure. That's why a lot of discussion is happening on the heart failure data. And so when you looked at the glycemic efficacy, you looked at the weight, as well as looked at the hypoglycemia, as well as the genital myocardic infection, which has been said about the SGLT2 inhibitors. Now we talked about the heart failure, and now talk about after the heart, does it have any kidney outcome? Okay, kidney outcome is also very important in this combination, and I think if you look into the Savatimi, Tecos, and Carmelina. So in this Carmelina, you can look into that. It's a predefined, pre-specified endpoint. The renal endpoint was taken as a predefined, pre-specified endpoint, and which has a sustained ESRD, a sustained reduction in EGFR and renal death. So definitely Carmelina has shown that definitely it was a benefit. The designing of Carmelina was also better than the other things, and reassuring long-term kidney safety effects. You can see almost all the three things, the three dots are on the ESKD or renal death, as well as pre-specified microvascular composite outcome, as well as albumin progression, all on the left side graph of the center line, indicating that favoring linagliptin. Okay, so summarizing, there are 10 advantages or 10 take-home points when you want to use this EMPHA-LINA. What advantage? So, as I said, addresses multiple pathophysiological defects, high efficacy with 3 to 5 times higher odds of reaching target HbA1c, early achievement of glycemic goal with durability, low risk of hypoglycemia, offers weight reduction, offers systolic and diastolic blood pressure reduction. The EMPHA has got cardiorenal protection and CV death reduction data, as well as linagliptin, proven CV and renal safety and possible renal benefit from the Carmelina trial. And absence of any additional safety concern, along with potential lower genital tract infection with FDC as compared to the SGLT2 alone. So once again, very important most point is, when you give it more and more number of drugs, it's very unlikely that sometimes the patient's likely to take less and less number of drugs. So try to keep your prescription as far as short possible. Sometimes, since diabetic patients with comorbidity is very difficult, you need to add more drugs. But by giving a combination, instead of giving 2 drugs, this fixed dose combination, the compliance also will be better. Okay? So thank you all for the patient listening.
Thank you for excellent talk on information which has come recently. Decade back we had TB only, we had some PLD, but now the control is excellent, outcome is also excellent. I hope he has given an excellent talk on that. Next speaker is Dr. Sangueredo, who is a well-known research oriented doctor. That's an important thing. He is always talking about all research outcome, excellent. So, whatever we say diabetes, we come across cardiovascular mortality because 70 to 80% of the patients of diabetes are going to die due to cardiovascular problems. How to prevent that? From the day one we speak about cardiovascular mortality, I think he is going to talk about that now. Welcome, sir.
Respected chairperson, senior doctors, my doctor friends, I'm here to make a presentation on present-day approach to CV mortality reduction in patients with type 2 diabetes. Time to build the cat with a particular focus on empagliflozin. Already Dr. Balamurugan, he has given a beautiful account on EMPA and a combination of LINA. I thank once again the chairperson for his nice introduction. Also thank Dr. Balamurugan for inviting me to share my views on this particular topic. My disclosures, of course, photography is allowed. What I'm going to do for another 15 minutes, present day approach to CV mortality reduction. The contents includes introduction, cardiovascular disease, intensive versus standard glycemic control, guidelines, recommendations, EMPA-REG outcomes, EMPRISE, real world. That is RCTs, we know the findings, and the real world findings, are they consistent? Next is EMPA heart trial. So, introduction. So, type 2 diabetes is an independent risk factor for atherosclerotic cardiovascular disease. It is often associated with multiple comorbidities like obesity, overweight, dyslipidemia, hypertension, which are independent risk factor in that hyperglycemia amplifies the risk. So, life expectancy is reduced by 12 years in patients of diabetes with previous CVD. On average, 50-year-old diabetes but with no history of vascular disease, that is diabetic patient without vascular disease, is about 6 years younger at the time of death than a counterpart without diabetes. So despite advances in therapies, life expectancy is reduced by multiple morbidities, stroke, myocardial infarction, combination you can see. So prototype of Indian patients. So non-smoker, type 2 diabetes, 6 years, 74 kg, BMI 27.2 kg and BP. A1C 7.9, FPG, PPG, serum creatinine, EGFR, urinary albumin creatinine ratio, total cholesterol. So what is the Q risk? So 10-year risk CV event 29.5. That is nearly 500 times higher than healthy Indian male of the same age. So the cardiovascular disease is a progressive continuum. So cardiovascular disease and type 2. So this particular survey published clearly shown diabetes is the second commonest comorbidity in cardiology OPDs in India. So the prevalence and prognostic impact of subclinical cardiovascular disease. Over 2/3 of patients of diabetes have subclinical CVD, as shown by elevated levels of high sensitive troponin T, which indicates subcordial myocardial damage, including the period of pre-diabetes, which can increase the cardiovascular event by several folds, including heart failure and the composite of cardiovascular disk and heart failure. So diabetes increases the risk of subclinical cardiovascular disease, and subclinical cardiovascular disease increases the risk of CV event. Subclinical coronary artery disease, based on coronary artery calcium scoring, CAD. So angiogram, so significant CAD. Over 2/3 of asymptomatic patients of type 2 have CAD. So heart failure, already discussed nicely by Dr. Mahadevan. So it is the second commonest. If you look into the prevalence of myocardial infarction, it is much more commoner. And it carries very high mortality. The stroke incidence is also very high, and heart failure with atrial fibrillation can give rise to stroke. So cardiovascular complications, asymptomatic effects, 2/3 of patients of diabetes, 2/3 of deaths are attributable to cardiovascular disease. So CVD is a major cause of morbid mortality. So LV dysfunction is twofold higher. Heart failure develops early, and CKD in diabetes increases CV mortality. Presence of CKD before the patient develops renal death, patient develops heart failure. Again, patient is a CKD and diabetes prone for heart failure. So intensive versus standard glycemic control. So during the study period, UKPDS, all this data have clearly shown reduction with reference to microvascular. So hyperglycemia is a strong risk factor for microvascular. That for microvascular, it is a weak risk factor. When patients in UKPDS were followed for many years, Patient in the intensive arm continue to experience the benefit of early intensive glycemic control in terms of reduced risk of microvascular complications. So it takes many years for the cardiovascular benefit of improved glycemic control on CV endpoints. So standard 2, intensive multifactorial intervention aiming at weight reduction, smoking cessation, glucose lowering, lipid lowering and BP lowering over a period of 7.8 years. Associated with significant impact on cardiovascular reductions. So major trials, cardiovascular outcomes with reference to glucose lowering, with reference to other glucose lowering drugs like Alexa, Examine trial with alagliptin, Sevatinib with saxagliptin, and TCOS with sitagliptin. So guidelines recommendations. So European Society of Cardiology, EMPA and CANA have shown a significant reduction in heart failure. Of course, DAPA, if you look into the data, already shown a significant impact on heart failure and composite of hospitalization for heart failure death and CV death. So ACC's recommendations. So start SGLT2 inhibitor, empagliflozin is currently preferred. So management of hyperglycemia patient at the type 2, this was projected by Dr. Balamurugan. So patient with evidence of ASCVD, GLP-1 receptor analog as SGLT2 inhibitor, as long as EGFR is adequate. Patient with CKD, definite benefit with SGLT2 inhibitors and compelling need, and these are all other drug categories. So glucose lowering medications, proven CVD benefit means that is with reference to the label indication for reducing CVD events. So both EMPA and CANA have shown reduction in heart failure. EMPA outcome trial with reference to the 3P means CV death, non-fatal myocardial infarction and stroke, significant reduction, CV mortality, significant reduction, as well as all-cause mortality compared to placebo. Right. So the all-cause mortality, the most robust and biased, 38% relative risk reduction. Again with reference to CV mortality, 38% relative risk reduction. Estimated mean survival, patients treated with EMPA, the survival rate has been increased dramatically, 1 to nearly 5 years. So consistent CV mortality reduction with EMPA. If you look into the Cox regression analysis model, the point estimate favors the use of empagliflozin with reference to all the parameters regardless of the A1C value, or the results of EMPA-REG outcome applicable only to patients of type 2. So in EMPA-REG, more than 19% of the patients had prior CVD. That includes CAD, PAD or prior CV event. In EMPA-REG outcome, 35% of the patients did not have prior CV event like myocardial infarction or stroke. And EMPA consistently reduced the risk of CV mortality across various presentations. So patient with myocardial infarction and patient with history of stroke and other cardiovascular. Next, CV benefits EMPA-REG applied to patients of type 2 with the documented CVD, and 2 of 5 asymptomatic patients of the type 2, there was significant subclinical CVD. So all-cause mortality outcome with the SGLT2 inhibitors clearly shown the benefit with reference to cardiovascular endpoint. That is cardiovascular death, hospitalization for heart failure. Of course, we are not supposed to compare the trials conducted with other glycosins because they are invalid, and the study protocol is defined, inclusion and exclusion criteria. So also the EGFR. CV death outcomes from SGLT2 cardiovascular outcome trial, EMPA-REG clearly shown the benefit. So each of the 3 SGLT2 inhibitors included nearly several thousands of patients. CV death reduction was observed only with this EMPA. So SGLT2 CV death, CV cardiovascular outcome trial, summary of evidence in established CVD, effects on CV, all-cause mortality is shown in this slide. So the benefit of DAPA on the CV death and hospitalization for heart failure was driven only by hospitalization for heart failure. But if you look into the trial, that is dapagliflozin, the EGFR cutoff was 60 with reference to EMPA-REG outcome 45 with reference to canagliflozin in credence trial up to 30. So that EGFR decides about the cardiovascular outcome. So benefit of EMPA on the CV death and hospitalization for heart failure outcome was driven by both CV death. Kindly look into the p-value, kindly look into the hazard ratio for CV death as well as for hospitalization for heart failure, and the composite of CV death and hospitalization for heart failure, p-value is significant. So consistent CV mortality benefit to EMPA regardless of heart failure burden. Next is CV death or hospitalization for heart failure on the top of care, 34% relative reduction. If you see the Kaplan-Meier curve estimates, The line of separation commences much early after randomization and continue to persist till the end of the trial. And the impact of EMPA on hospitalization, especially re-hospitalization, CV death or hospitalization for heart failure, hospitalization or any death, there was significant impact. So CV risk reduction in type 2, approximately 1 in 3 patients with type 2 have CVD, and very important, almost all patients had CVD in EMPA outcome, and patients with and without CVD included in EMPRISE. That is real world data. We have already taken into account the EMPA RCT, randomized control versus placebo. This EMPRISE real world evidence comparing the efficacy of EMPA with that of DPP-4 inhibitor sitagliptin, that is similarities with reference to algorithm position, and baseline characteristics no difference at all, and patients were well matched for background standard of care. So EMPA was associated with a 44% relative risk reduction. If you look into the hazard ratio, 0.58%. So the difference was significant and statistically and clinically meaningful. So hospitalization for heart failure in EMPRISE complements EMPA-REG. So the real world evidence data are consistent with the findings of the RCT, namely EMPA-REG outcome, and EMPRISE real world evidence results complement EMPA-REG outcome. 44% lower risk of hospitalization for heart failure compared to DPP-4 in EMPRISE, and in EMPA-REG outcome 35% relative risk reduction with reference to placebo. So this EMPRISE, it scores forward because it has been compared with active comparator. Next is EMPA-HUD, diastolic dysfunction. It's very important with reference to preserved ejection fraction. In this particular case, in this particular trial, empagliflozin was given 10 milligram for 3 months. They did a diastolic dysfunction analysis. So primary objective, secondary objective, inclusion criteria, exclusion criteria. The primary outcome, there was significant reduction in left ventricular muscle mass index, which is a surrogate marker for diastolic dysfunction. So EMPA mediates sustained decrease in plasma volume. And very important thing is it promotes differential effect on the interstitial and plasma volume. When you give furosemide, there is reduction in interstitial volume as well as intravascular volume, accounting for hypotension and reduced perfusion of the vital organs, whereas empagliflozin preferably affects only the interstitial volume. So EMPA and cardiac diastolic dysfunction, proof of mechanism, there is functional improvement as well as structural improvement. So the metabolic adaptations following SGLT2 inhibitor therapy improves glycemia, insulin sensitivity, beta cell function through its mechanism of action. And the combination of EMPA, metformin in treatment-naive patients, change in A1C, change in, very important thing is, patient with high A1C, it has brought down to optimal levels, and EMPA or SITA as an add-on to metformin, long-term A1C reduction was seen in EMPA metformin, and good glycemic control sustained over 4 years was reported in EMPA compared to glimepiride as an add-on to metformin, and EMPA versus glimepiride as add-on to metformin, there was 89% lower risk of hypoglycemic events, and weight loss significant in EMPA plus metformin combination, and systolic BP reduction was also reported with EMPA and metformin, and there is definite improvement with reference to eGFR. There was initial decline because of reduction in intraglomerular pressure. Those patients who have shown significant reduction in eGFR and changes with reference to creatinine value, that patient showed remarkable improvement with reference to cardiovascular outcome. So standard of medical care in diabetes, that is the endorsement from ADA with reference to EMPA, CANA and DAPA. So risk of CVD mortality has remained a significant and unaddressed challenge. ADA consensus statement recommends preferential use of agents with label indication of reducing CV events in patients with type 2 diabetes with a compelling need for atherosclerotic cardiovascular disease reduction as an add-on to metformin, and optimize clinical manifestation of risk benefit for each anti-diabetic agent. Thank you very much for your kind listening.
Very nice talk. As I told you, more various studies. The studies are so excellent, but it's a very good impression of mine. Very good. Thank you very much, sir. Next.
So we'll move on to the next topic. The general Lipton and its role in diabetic kidney disease. We have this different aspect of the action of phenylalkylamin and its role in diabetic kidney disease. We have a prolific speaker in Professor I. Penadavar, a senior colleague at Professor of Diabetology at Madras Medical College, Institute of Diabetology, Madras Medical College. Over to Professor Penadavar.
Respected Chairperson, thanks for kind introduction. And my talk is diabetic kidney disease and gliptins. And many thanks to scientific committee who has given the opportunity. And my agenda of talk will flow like this: the kidney disease in diabetes, a silent killer, early detection of DKD, management of comorbidities, that is hypertension, dyslipidemia and hyperglycemia, and role of gliptins in nephroprotection in diabetes. And coming to the epidemiology, of late the statistics are alarming with the incidence of DKD, and the prevalence is estimated to be 8 to 16% worldwide, and whereas in India it has been estimated to be 17%. So 17% means more than 1 in 6 individuals having DKD. It's a very alarming thing. And CKD incidence is estimated at 800 per million population in India. And in India, one more worst thing is diabetes is the most common cause of CKD. And according to these two Indian studies, prestigious studies, one was done in AIIMS, New Delhi, and the second was done in KIMS, Bhubaneswar, Orissa. And in both the studies, and it have been found to have more than 62.3% of patients of CKD have diabetes. The reason for CKD is diabetes. That's very, very alarming. And we all know, so diabetes is a very important risk factor for coronary artery disease. But if diabetes joins with CKD, then definitely the incidence of coronary artery disease is doubled. So you all know the basic reason for diabetes producing this cardiovascular morbidities through advanced glycation end products, through diabetic dyslipidemia, through diabetic hypertension, and reactive species, that is either oxidative stress and elaborated inflammatory markers. So everything contribute to both diabetic kidney disease as well as this cardiovascular morbidity. And this is according to this study, which was published in Journal of Clinical Medicine. That study was done by Alberto. It's the concept and the epidemiology of diabetic nephropathy have changed in recent years. Actually, in this study, the data were collected from 3 countries. So, all the 3 countries, they have reduced incidence of CKD. So, in Spain, the incidence of CKD was decreased from 645 per million population in 2002 to 600 per million population in 2010 in people with the end-stage renal disease. That is 7% reduction in adjusted rate. Actually, this is one example. And the second study was in USA. The end-stage renal disease report showed a stabilization. So no increase, no decrease, it was stable. And the third report, data from Australia and New Zealand, this Australia and New Zealand dialysis and transplant registry, that is AN's data registry, described the stabilization in the last 5 years, no increase or no decrease. Whereas in India, we have the year after year, the incidence of CKD is going up and up. The reasons for decrease or stabilization of CKD in the Western countries are earlier diagnosis and better management based on multidisciplinary approach, BP and glycemic control, and earlier better control of CKD progression and risk factors and use of the RAS inhibitors at early stage itself. And the third is increased awareness by primary care physicians about the prognostic importance of CKD and its consequences. Whereas in Indian scenario, I think at present the main culprit is the social media, the Facebook and the WhatsApp. They misguide our people, and whatever advice we give, the patients, they are not following. That's the one aspect. The other aspect is over 50% of patients with advanced CKD are first time seen when the eGFR is 15 ml per minute per 1.73 meter square. And the lack of screening awareness and difficult medical access, and these are the common problems with India. And the one more thing, so South Asians, we have different distinct phenotype like that of risk factor for coronary artery disease pertaining to CKD also. So we have higher predisposition for CKD. We have fourfold more likelihood to develop albuminuria, 1.45 times higher loss of GFR, that is more rapid progression of CKD, and higher prevalence of advanced CKD, that is stage 4 and 5 are very common in Indians, that is South Indians, and the multiple genetically predisposing mechanisms that pave way for this increased incidence of this severity of CKD in Indians, that is defect in RAS, that is inflammatory, more elaboration in inflammatory cytokines and dopamine, RAG and oxidative stress pathways. And this one more study, the Indian study, I Care for Diabetes survey, here it shows at least 1 in 2 patients of diabetes has CKD. This is also a very alarming. And the worst part, it's a silent disease, silent killer. So no signs or symptoms will be there until 70% of kidney function is lost. And the serum creatinine rises only if more than 50% of renal function is already lost. And primary care physicians screen only 20% of their diabetic patients for kidney disease before prescribing. And most of us still rely on the only urea, measurement of urea and creatinine alone. So majority of us are not screening for microalbuminuria or the estimation of eGFR, which are the main pioneer and very foremost important thing for the detection of this early CKD, which can be reverted back. So this is the natural history of diabetic nephropathy, and so you all know in the early stage, in the pre-stage, in the stage 1, there will be hyperfiltration, so that glomerular filtration rate will be little increased in the first stage, and in the next there is gradual reduction in the glomerular filtration rate, and over the period of 10 to 15 years and around 20 years, the overt diabetic nephropathy will be presenting, and after 25 years, almost majority of our patients lead on to end-stage renal disease. And similarly, the urinary protein excretion also, it's gradually increasing. In the initial stage 1, protein excretion may be normal, and in after 5 years of detection of diabetes, gradually the protein excretion goes up, and ultimately it reaches peak after 20 years or 25 years of detection of diabetes. And it has been documented in many studies. This is one study which shows it's an independent CV risk marker. So CV events have been found to increase by 19 to 40% as the eGFR declines from 90 ml per minute to 45 ml per minute. So as the worsening of proteinuria, albuminuria goes up, the CV events has also go up. And this is one more Cox regression analysis. So here the regression of microalbuminuria has been analyzed, which predicts lower cardiovascular risk. Whenever you aim at reduction of microalbuminuria, definitely you can reduce the incidence of cardiovascular morbidity and mortality. So the model also included sex, total cholesterol, triglyceride, history of smoking, everything. And the main thing is when you successfully treat microalbuminuria, you can reduce the cardiovascular risk. Then how we can manage this CKD? So these are the challenges in glycemic control in CKD. So one side we all want the glycemic target. So fasting target, postprandial target, HbA1c target. So if you are aggressively treated, then there is naturally the chance of hypoglycemia is more. And if you are using the new molecules to avoid any hypoglycemia, what's the thing? The cost. So most of our patients are middle class, lower middle class. They cannot afford the cost of therapy of the high-end, the latest recent onset, recently available medications, and of course off-target effects. So these three factors, the fear of hypoglycemia and the cost and other off-target effects, they produce some sort of clinical inertia among the treating physicians. And almost we should aim at normal HbA1c without the possible high side effect of HbA1c, the side effects. That is, and you all know the consequences of hypoglycemia. So hypoglycemia, it has two effects. One is electrophysiological effects and the second is hemodynamic effects. So electrophysiological effects produces arrhythmias and which can be lethal, and hemodynamic effects, and ultimately it lead on to this coronary heart disease. And this management of DKD is not a single entity. So it should be a comprehensive management. So starting from lifestyle changes, starting from the targeting the glycemic level, it should include other parameters like effective control of blood pressure and effective control of dyslipidemia, and everything should be in a well balanced manner. And of course, smoking should be stopped, and diet sodium intake should be restricted, and weight BMI should be optimal BMI should be achieved, and exercise when feasible, and 30 to 60 minutes of moderate exercise, and BP control, LDL control, everything we should follow. And these are the key considerations for anti-diabetic therapy. The drug should not produce any hypoglycemia. The drug should not have any renotoxicity, and simple dosing should be available, and it should be efficacious. It should be less glycemic variability and other comorbidities. Among these are the various molecules available for the in the management of diabetes. Out of this only the right side green, in any stage of renal disease, those drugs can be used. And as the CKD advances to stage 3, stage 2, some drugs cannot be used. So only two group of drugs which have been documented, which are very safe in across all the stages of this kidney disease, up to stage 4 or stage 5. One is repaglinide and other one is linagliptin. And let us go. Since hypoglycemia may exacerbate myocardial ischemia and may cause dysrhythmias, it follows that those medications that predispose patients to this should be avoided in this possible. And these are the things, among the DPP-4 inhibitors, these two, only linagliptin and teneligliptin are the well documented, which are safe, and we are documented to reduce the albuminuria in diabetic patients with CKD. So in next couple of minutes, I will talk about this DPP-4, two molecules, lina and teneli. And linagliptin lowers HbA1c effectively in patients at different stages of renal lipid. This has been documented in various studies, and there is no doubt for us. And the linagliptin permits the reduction of insulin dosage in patients with severe insulin renal impairment over 52 weeks. And this is a study from diabetic kidney disease endpoints in pooled analysis of individual patient level data from large clinical trials. It consistently showed reduction in renal events was mainly due to reduction in new onset microalbuminuria. It means the linagliptin is notorious to reduce the microalbuminuria. And albuminuria lowering by linagliptin is independent of improvement of glucose and blood. Initially we thought it was due to the reduction in the glycemic level, which is beneficial for this reduction in albuminuria. But it has been analyzed and documented that the beneficial effects were mediated through inhibition of podocyte damage, inhibition of myofibroblast transformation, and increased GLP-1 receptors. And this one more study which proved linagliptin alleviates podocyte injury and enhances glomerular nephric expression. And impact of teneligliptin on oxidative stress and endothelial function also have been emphasized in this study. And next I will take to you one more study wherein the teneligliptin was analyzed in various studies which proved reduction in this it's well tolerated in patients with any stage of renal impairment from normal to end stage renal disease, including those on dialysis, and improved glycemic control in long-term treatment. And teneligliptin patients teneligliptin was also tried in patients on hemodialysis. This was a trial. It has been very much beneficial even in patients on hemodialysis. This is one interesting and wonderful study which linagliptin was head-on compared with teneligliptin for glycemic control in type 2 diabetes patients with chronic kidney disease. And this was both the group of patients were put in with continuous glucose monitoring, and it was a crossover trial. First 6 days linagliptin was given, second 6 days teneligliptin was given. Almost the results were almost, there was no significant difference was identified. And in this study concluded the type 2 diabetes patients complicated by CKD, the effects of treatment of linagliptin and teneligliptin on CGM based mean average glycemic excursion were comparable. And this one more study, the real life scenario. The study published recently, where it shows it has given 3 valid points for teneligliptin. It significantly reduced fasting and postprandial plasma glucose as well as HbA1c reduction. It as well as it increases the eGFR by 846%. This is a very phenomenal thing. And reduction of serum creatinine by 15% and reduction in the proportion of patients with proteinuria. And so it consistently proved teneligliptin has effect on eGFR and serum creatinine in early diabetic kidney disease. And this is one more study which showed in the post-marketing surveillance study that teneligliptin reduces this glycated albumin, that is the fructosamine values, by minus 2.29%. To summarize, DKD is commonly a progressive condition that is associated with significant morbidity and mortality. In type 2 diabetic patients, kidney function should be monitored at regular intervals, at least once in a year. And DPP-4 inhibitors have good evidence of safety in patients with type 2 diabetes with renal comorbidities. And teneligliptin, nowadays it's emerging as a good option for this tackling this CKD, which is a cost-effective, which is very much beneficial for our middle class and lower middle class patients. With this, I conclude my talk. Thanks for patient hearing.
Thank you, Dr. Priyanka. Excellent talk on teneligliptin. I think teneligliptin will be a very good impression for the people writing for economical basis. For example, if you want to write gliptin, you think about the economical patient, because the patient is otherwise difficult. Very well. Thank you very much. The next topic is on insulin. As you know, type 2 diabetes and insulin cannot be separated, because insulin is so very important for type 2 diabetes, and its role is excellent and improves the glycemic control. Not only that, beyond that. So, to start, we think about basal insulin. Now, the talk is on prandial insulin. That is, how much the basal insulin can protect, how much the prandial insulin is going to help, and going to add, or going to be very useful for a patient to get good control and good outcome. I think this will be taught by Dr. Arun, who is a royal care physician, I can say. So, he is a very good speaker of various topics of diabetes, and today's topic is on insulin, particularly prandial insulin. Welcome, sir.
Thank you. Thank you, sir. Thank you for that very kind introduction. Thank you, Balamurugan, sir, for this opportunity. And my talk is on achieving optimal glycemic control and the newer, I wouldn't say newer, it's just a newly dressed up insulin. So these are my disclosures, and I think I should start with this slide. So I strongly protest attacks on our brothers and sisters. And after protecting ourselves, we'll probably go for the next 20 minutes on how to protect our patients from postprandial hyperglycemia. Now this link between postprandial hyperglycemia and A1C is well known, because, and it actually differs a bit from the West. The general consensus is that when you have an A1C of very close to 7, for example, if it is 7.4, 7.5, even maybe up to 8, the majority of the contribution for this HbA1c is primarily from the postprandial. Whereas if your A1c is more than 9, 10 and 11, traditionally we were taught to believe that the contribution from the fasting was much more. But actually it's not so, because most of these data have come from the West. When you look at the data from Indian patients who take quite a lot of carbohydrates with each meal, we find that even amongst HbA1c around about 8 or 9, there seems to be an equal contribution from both postprandial and HbA1c. So our contribution from postprandial towards HbA1c elevation is much more than in the West. So why am I talking exactly about postprandial? This is a very interesting topic because for a long time this has been debated. So what is actually the role of postprandial hyperglycemia in diabetes? We know when we treat diabetes, it's not just the numbers we treat. So nowadays we, welcome Dr. Mukherjee sir, I'm happy you are safe here. And the problem is, when you look at the postprandial, what is exactly the role? Because as I told you earlier, when you look at the way we treat diabetes, we're not treating the numbers. When we treat a particular patient with diabetes, we want to reduce the event rates, the microvascular and the macrovascular complications. Especially in our world, in part of in South India or even Southeast Asia for that matter, the problem with diabetes is cardiovascular mortality. In a tertiary hospital like where I work, if I walk into the ICU, if I have 10 patients with MI, 8 of them will have diabetes. One of them probably would be a smoker and the other unfortunate guy does not know why he has that risk. But whenever you see a patient in a OPD, whether he is just as an onset of diabetes or is established diabetes, the problem with treating this patient is that you should reduce his cardiovascular mortality. Now, what is the relevance of postprandial to the cardiovascular mortality? This is a very debated topic. Everything started with the DECODE study. Right? So actually speaking, DECODE study wasn't specifically powered or addressing the postprandial as such. What basically happened with the DECODE study way back in the 1990s was that the WHO and the ADA were trying to redefine the parameters, the values by which we diagnose diabetes. So there was some consideration as to what exactly will happen if we include a lot of people under diabetes. So quite a number of investigators from Europe got together and retrospectively analyzed the OGTT data from a very, very large population. To this date, this remains the largest epidemiological study which looked into the OGTT data. It ran into a lot of controversies. But the problem is what they found out was when you have a patient whose 2 hours OGTT qualifies him to be a diabetic. For example, if we have 100 patients whose 2 hours OGTT values are more than 200 and you call him diabetic, if you look at his fasting, 30% have normal fasting. Another 30% have impaired fasting. And only 30% actually have a higher fasting value which qualifies him to be a diabetic. So you know that early during the course of the disease, there is quite a lot of confusion because you may get only postprandial hyperglycemia. Your fasting might be normal. But at that point of time, there weren't much standardization regarding HbA1c. So there were a lot of disagreements regarding that. And of course, it ran into a lot of controversies because what it basically showed was that for postprandial hyperglycemia, there's a linear correlation between postprandial hyperglycemia and cardiovascular mortality. It did not tell you that treating postprandial hyperglycemia actually reduces cardiovascular mortality. These are 2 different entities. So what it convincingly showed us was that for a particular fasting value, the more the postprandial, the more the patient is likely to die of cardiovascular mortality. But does treating that postprandial bring down it? That's $1 million question. We do not have a specific answer even now. So the other one which came about were a number of studies like DECODA, which looked into Asian studies and then the other ones. But the real evidence came from one of the studies from Italy. There were 2 problems with doing things with the OGTT. OGTT, is not physiological. We don't take insulin we don't take glucose for our breakfast. We don't take glucose for our lunch, because our lunch and breakfast is a complex carbohydrate. So we have to look into studies which take postprandial hyperglycemia rather than OGTT. All right. So this is a very, very good study which came from Turin, which is in Italy, quite a large study, which looked into, this is the first study which actually looked into the postprandial in relation to HbA1c and fasting. All right. So all these persons who were in the study not only had the postprandial measured, they also had standardized HbA1c values, and they also had the fasting checked. So what they found out was that in 5 years, adjusting for the fasting and adjusting for the HbA1c and also adjusting for all the non-glycemic parameters like lipids, smoking, BP, etc., postprandial values linearly correspond to increase in the cardiovascular mortality. So this was the first study which clearly proved that independent of your fasting, independent of your HbA1c, there is a linear correlation between postprandial and cardiovascular mortality. So this was just for 5 years. So they followed it up for another 9 years. So after 14 years, the same trend continued. So what they clearly showed was that the two important predictors of cardiovascular mortality in a diabetic patient is not fasting. It is postprandial and HbA1c. Right? So if there are two important values which predict that your patient will land up with a cardiovascular event, these are postprandial and HbA1c. That's why treating postprandial becomes important. Right? So there's also another school of thought that the faster postprandial might be more important, but we do not have a consensus at this point of time, so I wouldn't dwell too much into that. So why is postprandial more dangerous? Now these are observational studies, but then you need to have solid science to back it up. We all know that a postprandial excursion of glucose corresponds linearly with most of the atherosclerotic markers. A postprandial increase, there's a very elegant study which was done where they infused glucose into the radial artery and found out what happens when there's a sharp excursion of glucose. Once there's a sharp excursion of glucose, there is increase in the endothelin. There is vasoconstriction. There is decrease in the endothelium nitrous oxide secretion. Right? So in other words, you are precipitating oxidative stress. So that explains why an increase in the postprandial generally increases all the atherosclerotic markers. So when you have a patient whose postprandial is high, not only is postprandial high, he also has a postprandial lipid increase also. These correlate together because these are dependent on the first phase insulin secretion. The one which has got a preformed vesicles, which just go out from the preformed vesicles within 5 minutes. So this is what is very important and which is required for a postprandial suppression. And if you look back at the pathology of diabetes, this first phase insulin loss is the first thing that occurs in diabetes. The second phase loss is later on. This was what I was alluding to earlier regarding the postprandial hyperglycemia and how it contributes to thrombogenesis, endothelial dysfunction and inflammation, all of which add on to have a cardiovascular mortality. I'm very skeptical about these target recommendations. These are not very standardized, but we might have these recommendations in the future where instead of having a 2-hour postprandial target, we might actually have 1 hour postprandial target. I believe Dr. Mohan has done a lot of studies on that, and he's also have found out that a 1 hour increase in the postprandial corresponds to development of cardiovascular disease. Now coming to the next agenda, when we talk about ultra-fast acting insulin. So this is human insulin response, which we have not been able to replicate till now. If you look at the regular human insulin, this is how it acts. Now you can see the mismatch between how the normal insulin secretion occurs and how the regular human insulin, that is the normal, the Actrapid that we use. Right? So it simply has got a very delayed peak because of the lower dissolution rate. We tried to solve this one by using aspart, which is basically the same as a normal insulin, except that at the beta chain 28, you substitute aspart instead of proline, which increases the dissolution, and hence you would find it's something closer to the normal insulin secretion. But then, even that has got some limitations, and right now we have got a newer, it's not newer as I said, it's just an insulin dressed up in a different cloth, which is the ultra-fast-acting insulin aspart, which is Fiasp. It's actually not a new molecule, it's just a fast-acting aspart, which is something a little bit closer to the normal insulin. So the onset of action is almost instantaneous, 4 minutes. So after injection, 4 minutes later, you have the onset of action of fast-acting aspart. So it is done by actually some absorption modifier with addition of niacinamide and arginine. This is not required for us. But what it basically does is that when you added niacinamide to that, it increases the permeability. So what it basically did was, you have a faster onset of action. Not only that, you have a more increased pronounced insulin action during the first half to 1 hour. So what basically this Fiasp can do is that it can reduce the 1 hour postprandial. Alright, is this important or not? Maybe time will tell. So it brings down the area under the curve during the first half an hour to 1 hour. So this is what I was alluding to earlier. So you can have greater insulin action, almost up to 74% of the insulin action within the first half an hour to 1 hour. So in those patients who eat quite a lot of starch and whom they have a postprandial, very sharp and fast postprandial excursion, this would be the ideal drug. So because since this is just the normal aspart, the duration of action and the total duration remains the same. So when we first compared human insulin with insulin aspart, this was what we had. We had an almost 38% gauge reduction in the area under the curve. This is what happens when you compare aspart with Fiasp now. So similar to what advantage we had with the human aspart over human insulin, now you have half an hour to 1 hour advantage with Fiasp compared to aspart. So nowadays this is all, we have to have evidence-based medicines, and they have quite large trials which happen both in type 1 and type 2 diabetes. I'm not going to bore you with all the trial details and design and everything. So what it basically showed was that in patients, especially in type 1 patients, this Fiasp might actually be of much importance in type 1 diabetes rather than type 2 diabetes. So in type 1 diabetes, when you look at the mean HbA1c after 52 weeks, there wasn't much, it's just 0.1. You might be wondering whether this 0.1 is significant, but in the end, the HbA1c reduction was much more significant. So if you look at the PPG increment at 26 weeks, this is what you get. So when you use Fiasp, you get more insulin during the first 1.5 hours, which is extremely important for patients with type 1 because you know they don't have any insulin whatsoever. The treatment emergent hypoglycemia was similar, except that when you have to anticipate hypoglycemia much earlier. There were a similar trial design for type 2 diabetes, and even in type 2 diabetes, what it basically proved that it was non-inferior. So when compared to aspart, it was non-inferior, and expectantly, the area under the curve in the first 1.5 hours was much significant. So what it basically tells us is that even when you use it for type 1 or type 2 diabetes, you are going to get quite a lot of insulin during the first half an hour to 1 hour. And that might actually reduce the amount of first hour postprandial glucose. The treatment emergent hypoglycemia was similar. As you would expect for this insulin, in summary, you would find that the HbA1c reduction for type 1 diabetes was much more pronounced than type 2 diabetes. In type 2 diabetes, probably, even I am confused about the usage of aspart. But then you don't have to worry about that because they're going to phase out aspart and you're going to get only Fiasp. So there's no point in comparing aspart and Fiasp in type 2 diabetes. But one of the very important aspects which you can use Fiasp is post-meal. Right, this is very important in hospitalized patients. Supposing a patient who has got a surgery, who has got a CABG, you don't know what he's going to eat and you don't know when he's going to poop out. All right, you get a lot of patients who take insulin, take the meal, then vomit. All right, then you are worried about hypoglycemia. So here is one insulin which you can use 2 minutes before the meal up to 20 minutes after the meal. So preferably you can use it after the meal in hospitalized patients. You can just find out how much they have eaten, find out if they are going to vomit or not, and then inject. So this is probably one significant advantage that FASP is going to give you as far as inpatient concerned. And frankly, I don't see any other advantage over insulin aspart. So in summary, we have ultra-short acting insulins which are designed to mimic physiological insulin release, which only can mimic, because basically, as I told you, you are injecting into the peripheral circulation, and as far as physiological insulin is concerned, you get it into the portal circulation. So there's no question of physiological mimication, but at least the onset of action can be mimicked. So aspart is a good insulin when compared to the normal insulin, and FASP is an improvement over aspart as much as aspart was an improvement over normal insulin. So we have clinical trials which clearly prove that it is as efficient. It's much more efficient in type 1 diabetes. In type 2 diabetes, as I told you, it doesn't offer much, but the convenience is much greater. And you can use that 20 minutes after the patient has taken his meal. So I thank you for your patient listening and take questions now. Thank you.
Adding to what Dr. said, probably the research is on to match the ideal
can expect that.
Any more questions from the floor? Before closing that, one important point that I would like to stress on, one point that when I was listening to was when I was talking on the role of gluten in patients with diabetic kidney disease, it was very surprising to see that one of the studies have shown that private care physicians is seeing only 20% of their patients for the renal involvement or renal impairment in their patients. It's very surprising alarming. So I would like all the audience to take home the message or the point that you need to screen all your patients for renal involvement or renal impairment. It's not necessary that you just happy with doing a lifetime plan and say that everything is normal. It is important that you look for albuminuria, or you do a urine routine, look for albuminuria. If there is not albuminuria, repeat the albumin another time within the span of 1 month. If 2 out of 3 are positive, we call it persistent albuminuria. So once the patient has persistent albuminuria, then you should ring an alarm bell saying that this patient is going for a kidney disease. Be it diabetic or not diabetic, whatever it is, that's the next question. But then this patient is going for a renal impairment. So this point I want to drive, and if the urine albumin is negative, again, don't rest assured, go ahead and look for microalbuminuria. These are all some of the points that I would like to take.
Adding to what Professor Dharma just said, that's why when screening for the kidney disease or diabetic nephropathy, one side is the stage on the EGFR, estimated EGFR. Other hand, it's based on the albumin to iron ratio. So particular EGFR, particular albumin to iron ratio, the staging is done. That's one. Second, even in uncontrolled diabetes, we can find, we cannot say microalbumin not delayed, but some cases we find that EGFR is high, 120, maybe. Some people might be thinking the kidney is extraordinarily working. Okay, there's a stage of hyperfiltration and a stage of diabetic 1, stage 1 diabetic kidney disease. So whenever you find a report saying that EGFR is high, you need to be careful that it's definitely a stage to identify and catch them at the stage so that all preventive things can be tried.
When you come across serum creatinine level less than 0.5 milligram, some of the labs they may come up with a report. That means so much amount of blood clears this amount of creatinine. That means EGFR will be more than 130 ml. So that should raise the possibility of hyperfiltration. So adequately control the glucose, both fasting and post-prandial hyperglycemia itself. By bringing down the hyperglycemia, we can reduce the renal plasma flow, as well as renal blood flow, plasma flow, and EGFR.
Over to Professor Sir.
If we may add to this, what is very important is that we check the EGFR, also calculate the EGFR. Remember, in a very emaciated 37 to 40 kilogram weight individual, creatinine of 1 is unknown. Actually, hardly has a muscle mass. So I think we should not take care to clinically judge the patient. So,
Thank you very much for excellent talk and you all listening so many hours from the morning onwards. And excellent to see you all, and it is very nice to see you all. Thank you.
Over to the scientific coordinator. Tomorrow's announcement.
Thank you, chairpersons. Thank you, speakers. With this, CUPID-2019 first day academic sessions have come to an end. Hope you all had a good academic week. Thanks for the patient listening. Thanks for the active participation. It's the time please join us for the dinner. Tomorrow morning, be here by 8 o'clock for the first academic session, clinical case discussion.
It will be very useful, We are giving a case presentation by clinical diabetologists and rare cases as well as common cases, so that how they are being handled and the panelists will discuss. Thank you. Thank you.
சொல்லுங்க. சரி சரி